At the outset, I thank Team Ideal for giving me this opportunity. I think, as you rightly told, this is the new kid on the block, the single-use duodenoscope, which is a very exciting topic. And uh, as we all know, in 2015-16, the thing started appearing in media that people who are even not knowing what ERCP has quickly recognize that there is a super bug which is causing deadly infections and is being transmitted by a tinted scope. And this kept on appearing in the main newspapers. And Akri is one of the non-profit organization which works independently. And the whole aim is to improve the safety, quality, and cost effectiveness of care across all healthcare settings. They bring out their list of hazards, and last 7 8 years the inadequate cleaning of complex reusable instrument kept appearing in their top 10 health technology hazards in each year. And the complex scopes like duodenoscopes are the main culprit. Why are these medical instruments so tough to sterilize? Duodenoscopes definitely have sickened hundreds of patients in hospital outbreaks, and that led to many experts demanding the device to be either redesigned or taken off the market. Why it is important to understand why only duodenoscope or a scope with a complex distal end, especially duodenoscope and echoendoscope with a elevator available. There are many steps in reprocessing: the pre-clean, the leak test, the clean again, rinse. So there are around 130 steps to clean a duodenoscope, and a manual has 120 pages. So there will be a mistakes in the manual cleaning, which leads to biofilm formation. And biofilm formation immediately starts appearing in the scopes, culturing from the scope, and they found that up to 5% of properly collected sample tested positive for high concern organism and 4.4 for low concern organism. In all, around 9% of the duodenoscope, even after high level disinfections, were still carrying the microbes. Now, how to get over this? Either we can redesign the scopes, we can bring more automation, we can bring more disposable instrument, we can have a better manual cleaning or others. Now let us see one by one what can be done. What if you improve the sterilization or disinfection? So if you do double high grade, high level disinfection, it does not eliminate positive bacterial culture from duodenoscope. At the most, you can bring from 9.4 to 4.8%. Even if you do ethylene oxide sterilization for 16 hours, the total elimination cannot be achieved, but you may be damaging your costly duodenoscope. So the permanent microbiological agent identified in critical endoscopes are still very, very high. So improving the sterilization method is not going to help. And this has been shown in this randomized control trial that whether you do one high-level disinfection, even do 2 times high-level disinfection, or use EO sterilization, still there will be 18.3% duodenoscope had some level of bacterial contamination. And the elevator only was the most commonly involved, but that was not limited to elevator, but working channel and elevator were also involved. So the known risk of pathogen is there, that duodenoscope cannot be cleaned properly. Even if you improve the sterilization, the pathogen is going to be there. Guidelines are insufficient. The true incidence of contamination is not known because it is impossible. There is no good way of taking the sample. There is no good way of uh, calculating the contamination. Microbes are evolving. So what is left? So the FDA is recommending now transition from duodenoscope with innovative designs. Now they are encouraging to change the conventional duodenoscope into and FDA believes that the best solution to reducing the risk of disease transmission by duodenoscope is through innovative device design that make reprocessing easier, more effective, and unnecessary. So what was that done? So there are two disposable devices available, which we'll be talking about that. But there are now enhanced duodenoscope design, especially the detachable cap, or sometimes the Pentex have now brought a detachable elevator. There are Olympus removable tip. Data are still emerging, and I could find one this randomized control trial from Rungson's unit where they used Fusionon scope with the cap, but they have not used the conventional duodenoscope as comparator, but the same scope without removing the cap. And they saw that if cap is in place while you are doing HDL, that is high level disinfection, the ATP means the strip method, whether the bacteria are present or not, was much higher if if there was a fixed distal cap. Fixed distal cap, the ATP was positive in 41 patients, while if the tip cap was detached and HDL was done, the ATP reduced to 20. So there is some emerging data showing that this type of cap, once we remove that, that allows to for mechanical devices like brush or cutters to remove the biofilm from the hidden areas, can still be a good option. But still, it will never bring to zero. The best method to bring it to zero is single-use duodenoscope. Now, there are two one Boston Scientific, Exalt D, and Ambu Cook single-use duodenoscope, which has recently been launched. There are studies available on Exalt Model D, single-use duodenoscope, and this eliminates contamination risk associated with reprocessing. The design is familiar, handle ergonomics, four-way steering, air water suction valve, all are there. We'll talk about this. And they have comparable to the conventional duodenoscope, like channel and the field of view, the direction of rotation, all are identical as compared to the conventional duodenoscope. Now, key questions for duodenoscope disposable devices are whether it works. First of all, it should work. And second, can we afford it? What about medical waste? Which patient to use it for? How will patient react to the availability of such products? So these are some of the questions. So let us talk about the working. And this is what we started once we cases. We had this duodenoscope, and we initially, because the operators, they immediately started using it with the ease was there. The stiffness is definitely more. The bringing to long position was slightly difficult. That was my personal opinion. But all the maneuvers, including sphincterotomy, balloon dilatation, removal of stones, placement of stents, and even to do was as easy as with the conventional duodenoscope. And you can see there majority of the stones were removed, and later on this is Professor Reddy doing the laser lithotripsy, and we could pass through the the spyglass through this duodenoscope and could break the stone very easy. So there is a clear-cut experience that this scope is quite good, and also has been shown in various studies, including this one published in GI endoscopy. 60 patients underwent different operators, and majority of the operators said that this is all as neutral as the conventional duodenoscope with all the procedures like biliary RFA, etc. So the usability is equal. Now the randomized control trial from Shams group have also come, where they conventional duodenoscope versus the single use duodenoscope, and they show that the success much better. The cannulation rates were equal, but the number of attempts they made to cannulate the bile duct was much lower with single use cohort as compared to the conventional duodenoscope. However, there was some stomach, image quality, image stability. These are all, they can be improved very easily. But in a very good data and the evidence in the form of randomized control trials are now available. They are very good. The good side, a good thing, if you compare these to the risk of contamination. Now it is very difficult to do a study where you will prove that the duodenoscope, single-use duodenoscope, will prevent contamination or do less infection. You may have to recruit 5,000 to 6,000 patients, which is almost impossible to do. But of course, the exogenous contamination will definitely be eliminated. The reprocessing setup is much extensive with you will not have any setup to do. The availability issue is presently not available throughout the globe. The cost is capital investment is high with reusable there in single balloon endoscopy, but the cost of the unit will be almost prohibitive in country like India. So the disposable device have, of course, as I discussed, cost, quality is now gradually, we are getting clear data. Durability during case is also important. Sometimes it may give way or there can be a damage, and then there will be additional cost to the patient. And once you dispose them, how to manage this medical waste. So these are some of the clear-cut cons. While pros are the inventory should be stable, and knobs. These are some of the ergonomic advantages, that they are lighter and may help in reducing the injury to the operator because it is so light. So in summary, I will just try and summarize in my last use in all cases. You can use this in cases where you are called for ERCP in, say, ICU or outside setup, where you may not bring up your own ERCP scopes. There can be, to protect the fleet, like patients with known multi-drug resistance organisms, like critically ill patient who are already harboring a multi-drug resistant organism. You will try to do those cases with single-use duodenoscope. In critically ill patient who would not be able to withstand a scope-acquired infections, like transplant patients, ICU patients, or patients with pressure support, hospitalized patients. In procedure at high risk for bacteremia or infection transmission, especially once you are doing cholangioscopy, biliary RFA, or stent placement, you may prefer to use this. In summary, duodenoscope transmitted infection have we are not recognized that and are likely underreported. The exact etiology is likely multifactorial, but most likely involves challenge in cleaning the elevator mechanism. The enhanced reprocessing solution adopt will vary based on local availability of options and regulatory issues. Multiple new technologies are developed in especially redesigning the distal end of the echoendoscope or ERCP scope. The future looks bright. While issue of cost and medical waste might remain, we are using the single-use duodenoscopes, which provides a definitive solution to this issue of hospital or the procedure acquired infections. With this, I will end my talk, and I will invite any questions if they are there.
And first of all, congratulations on your this seminal event. And Mohan has covered the entire very extensively. So, to my mind, there's no doubt that we do need a better sterilization system to prevent infection in our patients who require ERCP. There's no question about that. What we have to debate is the single use the only answer, or are the evolving technologies which will make reprocessing better going to be less expensive and more affordable? In fact, as Mohan said, that technically, if you see the usability of this scope, I don't think it has many disadvantages, except as he mentioned, this slightly rigid. And but whenever you use a new scope, you need to give some time before you get used to it. So we did cholangioscopies with it. We did pancreatic endotherapy, biliary endotherapy, and we found it to be easily masterable. So it's not something which has technical disadvantage. The biggest disadvantage is the cost and disposal of the equipment, because after all, you are adding substantial amount. So I think we went the same way when we came to single-use devices for various endoscopic, cardiology, and other procedures, and we started paying less and less attention to the reprocessable devices, and the technology advancement in reprocessing, because the device companies found it easier, more profitable to produce a disposable device and have a continued source of revenue rather than spend on research in new reagents or new technologies of the high grade disinfection or sterilization. So I think we need to take cognizance, invest in that aspect very heavily, and particularly I did a personal survey, and we are going to make it into a project to ask our patients, will they be ready to go for a disposable duodenoscope if that is available to them instead of the regular, and telling them the risk of infection and everything. And because we have a high load of post liver transplant patients, it matters how meticulously you do these patients, because in their incidence of cholangitis. If the cholangitis was only happening due to sterilization, then Mohan, and that in India, every patient will be having cholangitis, because reprocessing of duodenoscopes, the way we used to do it 10 years back, was not the way you will reprocess even your dining wares. So I think I'll leave you with the thought that we do need a better sterilization techniques, better design of the scopes, if that can be evolved, and single use is a very good addition for select patients. And unless the cost becomes such and a method of disposal of the device becomes such which does not add additional bio waste. Thank you.